affected by ACEs, and previous literature has hypothesized that multiple ACEs exposures increase the risk of diabetes more so than individual exposures. So my research question is there an association between ACEs and diabetes outcomes among Latinos age 18 and older in the 2020 to 2021 BRFIS data sets? My null hypothesis is that there is no association between diabetes and between ACEs and diabetes outcomes in this target population. And my alternative hypothesis is that there is a positive association between ACEs and diabetes in this target population. Moving on to my methods, I'm going to give a small background of the BRFIS. It's a cross-sectional survey that's administered in all 50 U.S. states and territories. It collects self-reported data on health and health services and interviews non-institutionalized adults only. It's administered by phone interview through landline and cellular phone, and there are core modules that are administered annually that collect data on things like prediabetes and diabetes, other chronic conditions, healthcare access, and more. And something to note as well is that there are optional modules that are available for states to opt into their BRFIS for that year, and ACEs are included in those optional modules. So again, my exposure is ACEs, and there were 11 questions measuring ACEs in the 2020 and 21 BRFIS data sets. There were 5 yes or no questions. So an example of that would be, does someone in your home abuse prescription drugs? And there were 6 questions measuring instances. So an example of that would be, how often did the adults in your home hit, kick, or beat each other? To prepare for analysis, all of my yes answers were coded as 1, and all of my no answers were coded as 0. All of my never answers were coded as 0, and all of my more than once or once answers were coded as 1. These values were then summed so that each individual received an ACEs score, and those scores were put into 1 of 4 score groups. So 0 would represent no ACEs, 1 would represent 1, 2 would represent 2 to 3, and 3 would equal 4 or more. Again, my outcome is diabetes, and there was one question in both data sets that measured diabetes data, and the question was, were you ever told you had diabetes? The original scoring for these answers were 1 equals yes, 2 equals yes, but also only during pregnancy, 3 equals no, and 4 equals no pre-diabetes or borderline diabetes only. To prepare for analysis, I kept yes coded as 1, and all other values were recoded as 0. Onto my study population, the inclusion criteria applied to my data were individuals who identified as Latino, individuals with no missing responses for any of the ACEs questions, and individuals with no missing response for the diabetes question. When I initially merged my 2 data sets, I started off with a total sample size of 840,651, and after applying all of my exclusion criteria, I ended with a final sample size of 10,994. Something to note is that I did have a significant loss in sample size due to that ACEs module being optional. So not every state opted to collect data on ACEs for 2020 and 2021. In 2020, only 29 states opted into the ACEs module, and in 2021, 17 states opted into it, with 11 overlapping states occurring between 2020 and 2021. Onto my DAG, I did use past literature to determine potential confounders and covariates, and the DAG here. Ones that I identified and decided to assess were age, sex, BMI, income level, education level, and employment status. For my statistical analysis, all of them were completed in SAS Studio, and all of my variables were categorical. I applied weights to all of my analyses using weighted variables provided by the BRFIS, and I performed a descriptive statistics, a bivariate analysis, and a multivariable analysis, which was a logistic regression in this case, and my statistical significance was determined at a p of less than 0.05. My DAG was referenced to determine confounders, but ultimately income was not assessed due to a large amount of missing data, and I did assess collinearity at a tolerance level of less than 0.10. Onto my results. So my table 1 demonstrates the demographic characteristics of my target population. So this population, 12.2% reported having diabetes, and 91.5% reported at least 1 ACE, with 41% reporting 1, 29% reporting 2 to 3, and 21% reporting 4 or more. Some more demographic characteristics. Over half of my sample were female. 39.4% of my sample were between the ages of 18 and 34. 30.1% of my sample had less than a high school education, and 60% of my sample was enrolled. Onto the results for my bivariate analysis. This was just testing the association between my exposure and my outcome without adjusting for any potential confounders. And the result of this association was that ACEs were not significantly associated with diabetes outcomes in this target population. And finally, onto my multivariable analysis. After adjusting for age, sex, education level, and employment status, ACEs were not found to be significantly associated with diabetes outcomes in my target population. However, a potential dose-response relationship was observed with my outcome and my exposure because as the amount of ACEs reported increased, there was also a slight increase in the odds ratios, and the p-values also decreased with the number of ACEs increasing. On to my discussion. The key findings of this study were that 12.2% of the sample received a diabetes diagnosis, and the majority reported at least one ACE. I failed to reject the null hypothesis, and although ACEs were not significantly associated with diabetes outcomes among Latinos, there was the potential dose-response pattern noticed with more ACEs reported. Onto the strengths and limitations of this study. Some strengths include that the BRFIS is a nationally representative survey as it's conducted in all 50 states and U.S. territories. I had a large sample size, so my results can be generalizable to Latinos in the U.S. specifically. Mine was one of the few studies to examine this association among Latinos specifically, and all of my analyses were weighted in order to control for potential bias. Some of my limitations include that the diabetes data in the BRFIS did not specify between type 1 and type 2 diabetes. The BRFIS is a cross-sectional survey, so causality couldn't be determined between my exposure and my outcome. I couldn't adjust for income, which was identified as a potential confounder in most of the literature I reviewed. There's also the possibility for selection bias, seeing that the BRFIS includes only non-institutionalized adults and participation in the BRFIS isn't mandatory. And there's also the possibility for information bias because individuals who experience certain types of ACEs, such as like severe neglect, sexual abuse, or physical abuse, are a lot less likely to disclose that information compared to individuals who experience other types of ACEs. And previous literature has also questioned the validity of self-reported diabetes data. So some of my implications include that ACEs are highly prevalent in Latino communities across the U.S., and although they are not significantly associated with diabetes, multiple exposures to ACEs can have the potential to have a greater impact on diabetes outcomes than individual ACEs exposures. So for some comparison to other studies with similar results, there was only one study that I examined during the literature review that examined this association among Latinos specifically. It was conducted by Yabre et al. In 2017 and was titled The Social, Cultural, and Ancillary Study of the Hispanic Community Health Study. Once again, this was the only other study found focusing only on Latino populations. ACEs was determined using the CDC 10-item ACEs scale, and diabetes size was obtained from the fasting blood draw of the participants. And the results of this study found that ACEs and diabetes were not significantly associated, which corroborated the results of my study. For studies with different results than mine, an example is a study conducted in 2023 by Zhu et al. This was titled the Chinese Health and Retirement Longitudinal Study. Again, ACEs was self-reported in this study as well. However, diabetes size was obtained from a fasting blood draw, and their focus was primarily on Chinese older adults. And they found that ACEs and diabetes were significantly associated. And the main differences for this study obviously were the racial background of participants, as well as the age of the sample, because this focused on older adults, and my population was primarily between the ages of 18 to 34. So for some future recommendations, it's recommended to examine the association between ACEs and other chronic illnesses among populations that are most affected. And these include Latinos, African Americans, and multiracial individuals, as well as individuals living at or below the federal poverty line. More longitudinal studies are recommended as well, and using biomarkers to determine diabetes status versus self-reported data, and also using those biomarkers to differentiate between type 1 and type 2 diabetes. It's also recommended to have early intervention for children, both at risk for ACEs and diabetes. And this can include screenings at doctor's appointments or examining the social determinants of health of these children in order to connect them and their families to appropriate resources. It's also recommended to provide health education or parental classes for parents whose children are at risk for either of these conditions. onto my conclusion. Again, ACEs do have a high prevalence in Latino communities in the U.S. specifically, and although they are not significantly associated with diabetes outcomes in the U.S., there is a potential that multiple exposures to ACEs do increase the odds of diabetes in the long run. Future research should examine the association between ACEs and chronic illnesses among populations at risk, and more longitudinal studies should be conducted examining this association. And finally, for my acknowledgements, I'd like to thank all of my committee members for all of their feedback and continued support, my capstone professors for their support and feedback throughout the year, and my family and friends.
All right, thank you, Amanda. That was really, really well done. I just sort of with a few questions here. Can you talk about this approach to sort of modeling the ACEs as a summary measure, right? Like in my mind, those should not be equally weighted, right? You wouldn't expect that they will be, but when you sum them, you assume that they would be. So I'm just curious, like, why you decided to go with that approach, and whether maybe you considered any other alternative approaches?
Yeah, so that was something that I looked into a lot. Most of the studies that I read did use that kind of scoring method, kind of like 0 versus like 1, and then the one after that did differ a little bit. So I just wanted to be consistent with the literature. I did take that into consideration because, like, you know, an ACE technically could be considered, you know, living with divorced parents versus, you know, somebody going through sexual abuse or like physical abuse. So that was something that was considered, but ultimately I did decide to kind of just go with what was consistent with what I read.
Very nice. And then I was kind of struck by your comment about the sample being non-institutionalized and non-incarcerated folks, right?
Yeah.
So I'm wondering whether ACEs increases your risk of being incarcerated, and then so maybe we're underreporting. I mean, I think ACEs are probably underreported anyway, but given that we're not surveying those who might have higher odds, but like, what do you think that does to the prevalence of the ACEs, and like how maybe the impacts on your study?
Yeah, I do think that it does have the potential to skew my results a little bit. I did look into that, and I found in one study it examined that over like 90% of incarcerated adults did experience ACEs in some point. So I do think that that was part of that selection bias right there. It could have, you know, if those individuals were included, I feel like I could have controlled for that a little bit more. But
okay,
yes.
And then I'm wondering also, because from the ACEs which occur in childhood to diabetes, which is probably occurring later in adulthood, mid to adulthood.
Yes.
I wonder if that just timing is just so far away that like it's just too distal of a relationship to see something. And I'm wondering, like, what's your take on the literature looking at maybe like more proximal outcomes, maybe like ACEs lead to substance use or other things that might increase the risk of diabetes. So
yeah. So something that I did examine, because a lot of studies did talk about like ACEs causing a lot of unhealthy coping mechanisms, and you know, in adolescence and young adulthood, that did obviously lead to like chronic conditions later in life if they were persisted with. So I do think that that could have been like something to examine, but ultimately, just because I had done some like previous work examining like CSA specifically and how it's related to chronic illness later in adulthood, I thought that it would be a good way to kind of not just look at CSA, but different like adverse experiences and how that has like an effect on chronic illness later in life. But that is a really good point. I did really consider a lot of like internalizing factors, a lot of like depression, anxiety, and stuff, and how that leads to like unhealthy health behaviors.
Thanks so much. I'll pass that on to Dr. Julie.
Wonderful job, Amanda. Yeah, I wanted to ask you a little bit about, so the outcome is self-report of have you ever received a diagnosis, right? So I'm going to ask you how you think that being the outcome could contribute to bias.
Okay, so some of the, looking at the literature review, I did kind of look at like the validity of like self-reported diabetes data, because personally I did feel like getting those biomarkers was a lot more accurate to determine that status than the self-reported data. So individuals who are kind of unaware of their diabetes status, maybe, you know, not remembering like if they were diagnosed with prediabetes, something like that, that eventually did lead to diabetes outcomes, that could lead to people saying like, oh no, I don't have it, but they actually do, or individuals saying like, oh, I do have it when they actually don't. So that kind of does skew my prevalence a little bit for my outcome.
Yeah, well, I was thinking specifically around like you have to access care to have that diagnosis,
Right, yeah.
So I wasn't sure maybe both ACEs and diabetes, or having diabetes might be associated with whether or not people were regularly accessing care. So it might be something to think about as kind of a mitigating factor that could kind of reduce the likelihood and bias your result towards the null.
Mm-hmm.
Also, I wanted to say, so you said, do you have a list of the states where they did and didn't, like the ones that they did and didn't include?
Yeah, I do. I didn't, just because one of them for 2020 was like 29 states and for 2021 was 17.
Okay.
So I didn't include all of them, but I do have, sorry. So sorry. Let's try again.
So if you have a list, let us know. But if not, I was mostly thinking that it might be interesting for you as you're finalizing your discussion to take a look at what was and wasn't included and see if in the review of your literature, if there was anything in your literature that might have showed that these states that weren't included may differ in any way kind of around diabetes cases with the ones that were included, right? Because that'll help you to better understand if your findings will be generalized to some other states as well. So it's otherwise a generalized sample.
Great. Yeah, that makes a lot of sense. Thank you. I'll look into that for sure.
Good job.
Yeah, Dr. Schaefer?
Yeah, no, nice job, Amanda. Just a quick question. You didn't have, all you had was diabetes, yes or no. So I know you didn't have differentiation between type 1 and type 2.
Yes.
And you also did not have age of onset, right?
Right, yeah.
Okay. So think about age of onset for just a minute. Because that, with something like ACE, adverse childhood events, it could be that the issue is whether they get diabetes sooner versus diabetes at all.
Right.
And so think about for a minute what that may have done to your results if, in fact, ACE affects when they get diabetes versus if, and how that would have changed your findings. And this is a guess, I know. I'm just asking you to guess. What do you think it would have done if you'd have been able to measure age of onset as well?
If I had to guess, because I did read again that ACEs do, lead to a lot of unhealthy coping mechanisms and health behaviors, in young adulthood. I would guess that it might potentially cause onset to be a little bit earlier on versus in the general population, usually onset is early 50s to early 60s. So if I had to take those factors into consideration, then I probably think it would cause a lot earlier onset than just the regular population.
And it may be that since you had an age cutoff here, it may have affected your findings as well. So yeah, I think that's an interesting scenario here because certainly, we're finding, as you know, more and more things are related to adverse child events. And, it could be that getting diabetes 10 years earlier than you would have is a big deal. So that's something that would be worth looking into as a recommendation as well. But I think overall you did a very nice job.
Thank you.
Thank you. I think we'll ask everybody to step out one more time. We'll deliberate and then we'll bring you back in.